Hello, my name's Richard Harvey and I'm the National Clinical Training Manager for Jiraffe. I'm excited to announce that Jiraffe will be launching a new series of educational and helpful videos in the coming weeks and months. This will be structured around postural management and the use of our equipment. It will include videos on assessing for seating and the implications of that within a 24-hour postural management plan. We'll take a look at some of the theory behind why 24-hour postural care is so important to our client group, and how the use of adaptive equipment can positively impact a child's function and their independence. We'll take a look at the Jiraffe range, we'll delve into the features of the products and look at how the systems work, and also we'll show you how to get the best out of your equipment. So please stay posted, join us on social media, and look out for the new articles, blogs and videos over the next coming weeks. Hello, and thank you for joining me for this presentation on assessing for seating, the implications within a 24-hour postural management plan. My name's Richard. I am the National Clinical Training Manager for Jiraffe. So if I start by just giving you a little bit of a brief outline of myself. I've got 8 years experience working within the NHS in a variety of different settings. This has included mental health, older adults, and more recently, around 3 years, working with paediatrics. That, with my experience here at Jiraffe, has included a lot of assessing people's postures and also recommending equipment provisions in seating, standing, sleeping, bathroom and mobility. Most recently, in fact, I will be completing this month, hopefully, my postgraduate certificate in postural management for people with complex disabilities, and I undertook that up in Oxford at the Centre of Enablement. If you are interested in furthering your knowledge in postural management and specialising in postural management, then I can't recommend that course enough. In fact, majority of the content in this presentation is structured around the teachings up in Oxford. So if we get started, some of the things that I'm looking for you guys to gain from this presentation would be to either gain or develop your understanding of the importance of 24-hour postural management and how seating fits within that programme. We're going to take a look at the internal and external forces that are applied to the body and how that affects our posture. The importance of early intervention, especially for gaining better outcomes for children with neurodisabilities. Then we're going to take a look at some practical tips in assessing children, specifically for seating. And then towards the end of the presentation, I'm going to introduce you to our assessment tool for seating. So we're going to take a bit of a look at that later on. So if we get started onto the presentation, the first thing we really need to understand before we understand how to manage someone's posture is posture itself. So I've got a quote here on screen for you from A. Whitman back in 1924, who defines posture as the attitude or configuration of the body against the constant struggle of gravity. So in a nutshell, that really is what posture is. It's our bodies fighting against gravity to become as aligned and as functional as possible. But when we're looking to manage someone's posture who's got complex disabilities, we need to understand that a little bit further. So I've got another quote on screen in front of you from Pauline Pope, who looks at posture a little bit deeper. And you've got some examples there on bullet points of some of the definitions there. So how our bodies conform to the supporting surface, how our different body segments offload weight differently, and also the interactions with any internal or external forces that the body is under. Postural management could be summarised as the holistic approach to managing the posture, movement and function of those who cannot do it for themselves 24 hours a day, 7 days a week. Now, 24/7 sounds like a lot, obviously, but the key phrase there really is 24 hours a day. As gravity is completely bearing down upon us for 24 hours, we need to look at how our body reacts to that within a 24-hour period. We'll delve a little bit deeper into that a little bit later on within the presentation. So in terms of postural management, there are a multitude of benefits of managing someone's posture, but they can be summarised into three main aims. These are, first of all, function, so allowing the person to be as independent as possible. second, to minimise damage. So minimise the risk for musculoskeletal damage or compression of internal organs, for example, and the reduction of energy expenditure. So reducing fatigue, allowing someone to be as functional as possible. We'll delve into each one of these a little bit further. So when we look at function, the things that we mean by function is our activities of daily living, really. So that includes eating, sleeping, breathing, going to the toilet, things like that. One of the most important elements of that, I'd say, would be communication. For example, if you have a child that is non-verbal, they might kind of be sat in their chair in quite a kyphotic posture, so their gaze might actually be directed at the floor. If they're not able to verbally communicate, they might rely on their eye contact quite heavily. So if they're in a posture where their gaze is directed at the floor, they're not really able to engage in their environment, communicate with others, and that really detaches them from society. Also, things like play and engagement within the classroom as well. We mean all of those things when we talk about function. When we talk about minimising damage, so we're looking to prevent or minimise skeletal deformities, for example, scoliosis, kyphosis, any rotation of the pelvis. The compression of internal organs, so this doesn't allow them to function as well. If we're in more compressed positions, they have more difficulty in actually doing what they're supposed to do. The formation of contractures, so the shortening of soft tissues like muscles and tendons, that can actually stop us from being able to be in a certain posture, for example, standing. So if we have fixed contractures in our hips and knees, it makes it very, very difficult to gain a safe and effective standing posture. So also the lengthening of muscles and tendons, sorry. So when we talk about that, we're talking about like elasticity of the soft tissues. So that's the ability for forces to be applied to the muscles and to the soft tissues, but then for them to regain their original shape. Once they have been overstretched and over-forced, that can go into what's called plasticity. And the evidence suggests that people with severe neurological conditions, once they've overstretched those muscles, they can't actually regain their original shape. So it's something that we need to really be careful of and really manage before we get to that point. So if we take a look at the third aim of postural management, which is reducing effort and energy expenditure. Now, human beings are innately looking at ways to conserve energy, and this is believed to be from the Paleolithic days where we were all hunter-gatherers, and we had to conserve our energy in order to gain access to food. But if we look at nowadays and look at people with disabilities, if they spend their days utilising their energy just in order to keep themselves upright or be in a safe and comfortable posture, then they're not able to engage in their activities of daily living. They're not able to engage in their therapeutic programs, so their outcomes aren't going to be as successful. Which brings me on to my next point around management versus treatment, and obviously both should be used together, but there's just one statement here that a tutor on the Oxford course made, and that is that management without treatment can be effective, whereas treatment without management not so much. So what that really means, if we take, for example, a hamstring lengthening surgery, which is obviously a treatment, so people's postures and lengths of hamstrings can be hopefully managed before the need for treatment. Obviously in some circumstances that's not the case, but certainly after that treatment, the length of that hamstring is going to have to be managed, whereas if it's not, then the treatment will be not as successful. So I quite like that statement, and I think it really kind of defines why postural management is so kind of important. So if we move on to what compromises body structure, so that can really just be summarised in one phrase, and that's force. So when we look at what a force actually is, it's something that has magnitude or size, it's travelling in a direction, and it has a point of application. And what a force tends to do is either it moves an object, or it stops moving an object, or it changes the shape of an object. The biggest force that is constantly on us, which we've already mentioned, is gravity. You've got your slide there of the human sandwich there. So that is basically depicting gravity compressing the human body into the supporting surface. So that's happening constantly to all of us. And that's throughout the day we can kind of feel ourselves getting uncomfortable, and we can just adjust our position to make ourselves more comfortable. However, people with disabilities aren't always able to do that. So what happens to a person that isn't able to adjust their position against gravity to become more comfortable? The next slide here we've got of a gentleman that's obviously not had a great deal of postural management, and we can, if we kind of take a look at this photo, you can see that it appears that he's developed quite a few contractures of the knee and possibly hip, and that his feet are quite plantar flexed now. So if we think of seating this gentleman, unfortunately this would be a very difficult task to do. A few other kind of points to make on this slide would be, if we look at the position of this gentleman's legs, so we can see that his legs have fallen over to the left hand side, but if you take a look at his pelvis, it's not quite easy to see, but it's quite likely that has actually rotated to the right. So what's happening there is that gravity is bearing down on his knees as kind of what we would call a moment of force, and that's forcing his knees into the ground. And on the other side of the fulcrum, you've got here the right hand side of his pelvis, which is being forced by gravity into the ground there. So in terms of plasticity of his soft tissues and bones, if that has been forced into the ground so far as to have gone beyond his natural point of mobility, then it's likely that those issues could become fixed, and that they won't be as flexible, and we won't be able to correct them. So moving on to what kind of forces that the body is under. So we've got compressive and tensile forces, so that's quite common with muscles that contract and extend constantly. We've got shear force and friction, so that's something we really need to be aware of, especially in seating. So that's where one object is moving against the supporting surface. So if we think of seating and the seat itself, if a person is kind of moving forward and the seat itself is staying where it is, there can be a lot of issues around pressure, and it can create things like pressure ulcers and further complications. Other forces such as buckling and rotation. So I really like the example of a 30cm ruler. If we apply forces to the top and to the bottom, it's quite sturdy, it's quite firm at first, but you just get to that one point where you're able to apply enough pressure and it will just be really easy to bend and to move. I kind of like to think of that as the spine, in fact. So it's quite hard at first to get the spine out of position, but once it has become curved, then gravity forcing on the top of the head will create that to become worse, basically. So if we look at body composition and how the body behaves, we're quite naturally unstable and we're very flexible. We've got different body parts and segments that weigh different amounts, and that can sometimes put us out of balance. We also have internal stabilising mechanisms. However, people with neurodisabilities, sometimes these mechanisms, they don't work as well, or they can't function with them, so they require some external supports. We're quite vulnerable to damage, so whether this is a traumatic injury or just the effects from posture that we've seen in previous slides. Also our soft tissues, they adapt over time. So you may have heard the phrase someone becoming chair-shaped. What this basically means is, for example, a disabled person that's been placed in a seated position, a seated posture for a very long time, and that's their main postural position, that they've actually adopted that shape now. So perhaps their knees and hips have become fixed at the 90 degrees that you need to be able to sit, and because they haven't been able to follow through with their full range of motion, those joints have now become fixed at that angle. So what happens to the body if it becomes unstable? So we become unbalanced. That can make us feel very unsecure and unsafe. That can make our muscles tense up as well because we don't feel safe. So if we think of maybe a child with a high extensor tone that doesn't feel safe and secure, it's only going to make that symptom worse. If we don't feel stable, then we might seek support. We might seek to create a wider support for ourselves, and we won't be able to undertake our activities of daily living if our main aim is just to stay safe and stay stable. Then our whole world might revolve around just becoming stable. So if we take a look at the next slide, we've got a young chap on the plinth here. So with the question whether this young man is stable or not. So he might be balanced. It seems like he's kind of propping up on the left side of his pelvis there and using his arm to kind of balance himself, with his right arm being kind of a counterbalance. But in terms of whether he's stable or not, then he isn't. And also the main thing to take away is that he's not able to engage with his surroundings. So if he was in a classroom, he wouldn't be able to engage in any educational program that he's within. He's not going to be able to play with his peers, and all of his effort, all of his time is just focused on being sat there and maintaining that posture. So really what we're looking to do is take that away from him so he doesn't have to focus on that, so he is able to become more functional. So when we think about stability, again, there's 3 characteristics. There's always 3. It's always a rule of 3. And they are: the centre of mass needs to be within the base. It needs to be a wide base of support, and the centre of mass needs to be low to the surface. So this next slide, if we're looking at stability, I would say that this is not stable. Obviously the truck is not got a wide base of support in comparison to the load. The centre of mass is quite high up within the base, and it's not low to the surface at all. The next slide, we've got a pyramid, which is much more stable. We've got a wide base of support, centre of mass is within the base, and it's low to the ground. So we know that is stable. So if we take those principles of stability and put it into seating, what do we know? So we need to create a wide, stable base. So how do we do that? The first thing that we need to focus on is the pelvis, the thighs, and the feet. So that's our stable base there. That's creating our pyramid. We naturally sit in around 10 degrees abduction, creating that wide base of support. And if we really plant that pelvis in the right position, then everything that's happening above and below the pelvis should fall into place. So the pelvis really is a cornerstone when we think of postural management. So the other thing to mention at this point as well is around feet and what to do with them. It can be quite a tricky situation and quite a tricky conversation to have with some parents about feet, and where to put them and whether to strap them in or not, in particular. By no means am I saying that every child's feet need to be strapped in. However, if the child hasn't got the ability to adjust themselves and their feet might tend to kind of lean to one side, or they might push their feet out quite often, that really does affect the pelvis and what the pelvis does. So it's really part of your assessment to figure out whether that's going to be necessary, and unfortunately have those kind of conversation with parents whether we think, for the purpose of that chair and what they're looking to achieve, whether or not you might need some either sandals or foot straps or something to really help to plant the feet in order to create a stable base. So moving on up to the trunk and shoulders. So here we need to remain stable because we've got quite a long trunk, but we also need as much mobility as possible as we're going to engage with the surroundings as much as we can. So whether we're interacting at school, in a job, feeding, having a look around, seeing what our neighbours are doing, that sort of thing. So when we think of supports that we might need around that area, we need to kind of consider quite flexible supports perhaps, and things that might be able to be removed and taken away or flipped away. So it's just something to think of whilst you're doing your assessments. And then finally, our arms and head, we need to encourage as much active movement as possible. And again, that's because we want to encourage as much engagement and as much communication as possible. So we want arms to be able to reach and work with our therapy goals about bringing things into midline, for example. And we're all nosy, we all want to know what's going on, so we need to have a good look around. So when we are talking about the gold standard of seating, we think of feet in plantigrade, so flat on the floor. We think of the pelvis in a neutral position with the sacrum supported and the spine's able to be stacked upon it. Like I mentioned before, our legs abduct to around 10 degrees naturally, and we've got our spine and all our trunk stacked upon our pelvis nicely. We want our head and shoulders aligned over the spine as well, so that we're not creating that kyphotic or protracted position. So again, we've got as much movement as possible. And all of our joints are at 90 degrees angle, so all of our hips and knees and ankles at 90 degrees. So a lot of that is kind of gold standard and what we strive for. Unfortunately, there's some children that aren't going to be able to achieve all of that. So we also need to look at different ways that we can accommodate for things that some children aren't able to achieve. So although it is the golden standard, it is important to remember that some compromises sometimes need to be made. So I just wanted to touch upon early intervention. I'm sure you are all aware of the importance of intervening early, especially for children with neurodisabilities. There's a great deal of evidence around, especially standing, that the sooner that we can get children in a standing position, the better their outcome, whether this is around bone mineral density, the formation of their hip joints, and also reduction of spasticity. So we have just a simple physical development chart here, which depicts at what points in time a child is likely to reach one of their milestones. And if they are not reaching their milestones for whatever reason, it's a red flag for us to kind of build a bigger picture of what possibly could be happening. So these postural development milestones, they include fine and gross motor skills, communication and social and sensory milestones. Now there's a plethora of different signs that could suggest an impaired motor development. These could include things like poor head control, not making any eye contact, not tolerating being in a prone position or tummy time, asymmetric primitive reflexes, and the asymmetric tonic neck reflex, for example, and delayed hand-to-eye skills. So why is it that children with disabilities require seating? So first of all, to meet the three aims of their postural management, we want to reduce their energy expenditure, we want to minimise any damage that could be caused, and we want to increase their function. We want them to be included, be able to communicate, their digestion, their respiratory system. It all works better in a better, more aligned posture. So moving on to the anatomy now. So if we just look at different body segments and some of the common kind of issues and how we might be able to detect these problems. So if we move on to the pelvis first of all, you've got a description there of a neutral pelvis, so you can kind of see that that's all nice and aligned, which obviously means that the spine is nicely stacked upon it. The next one here, we've got an anteriorly tilted pelvis, so that's where the anterior superior iliac spine is coming forward, which what that causes is an actual hyperlordosis of the lower part of the spine, which can cause a lot of different problems further up the body as well. So one of the ways of finding out whether this is happening or not is just feeling for the ASIS yourself with your thumbs, palpating the pelvis and trying to locate the reverse, the PSIS, and seeing if that's aligned, if that's tilted forward or tilted back. We've got a posteriorly tilted pelvis as well, which is image C. That basically means that the ASIS is coming backwards now.
And what that means is that, in terms of sitting anyway, that a lot of the pressure is going through the sacral bones of the pelvis. We often call that sacral sitting. And that actually has the opposite effect to the anterior tilt of the pelvis, where the lumbar spine is now flattened. Instead of having a hypercurve, it's now flat, which then can lead to a kyphosis at the top of the spine as well, which again would lead us to that slouched posture where it's going to be more difficult for someone to keep their head up, to engage with their surroundings. This is depicted again on the next slide, so you've got a couple of different examples there of what a sitting position looks like with those pelvic issues. And then the last one on the far right of your screen there, you've got pelvic obliquity. So it's demonstrated better on the next slide. What that means, it means that one side of the pelvis is higher than the other. And on this slide here, this is the back of the pelvis, so that's the posterior superior iliac spine. And you've got two nodes there that you can palpate for. It's usually easier on the front, so if you're looking for the ASIS, you'll be able to feel whether one is slightly higher or one is slightly lower. And that is really important to find out, because if that problem is flexible, if we're able to shift that pelvis back into neutral, then we very much need to. And if it is not, then if it's fixed in that position, it's going to cause quite a few issues possibly. So you can see the ischial tuberosities, the sitting bones, at the bottom of that slide. You can see that the right, or the one on our right hand side, is lower than the one on the left. So what that means is if we're sat down, all of our weight and all of the pressure is going into that one ischial tuberosity. And over a long period of time, if we remain in that posture, we could develop some kind of pressure issues as well. So it's really important just to see if that is a case, and if it's flexible or if it's fixed. So in the next slide here, we've got a bit of pelvic rotation. And why I thought it was important to show you this slide is because it appears that we may have a leg length discrepancy in this slide, but really what it could be is that the pelvis is actually just rotated. If we rotate our pelvis on the right hand side, then if you do that in your chair now, you probably feel that your right leg is coming forward, so your right knee is a bit more forward than the left one. So if we're just doing an observation of that, then our first instinct might be that the child has a leg length discrepancy, which is very, very different to a rotation or obliquity of the pelvis. And it's really important to decipher whether that is a rotation rather than an actual leg length discrepancy, because what we want to achieve in a seating system is completely different. So if it is a leg length discrepancy, we need to adjust the length of the seat per leg and have a split seat, or an option to add a bar to support the rest of the leg. We need to look into that. However, if it's a rotation that can be corrected, and we don't correct it in the seat, then it's possible that will become a fixed rotation of the pelvis. So really gathering that information is super important, because if it is flexible, then and we don't correct it, then we are going to accommodate it, and potentially that will lead to a fixed rotation of the pelvis. So if we look at the spine now, I'm sure you're all very aware of a scoliosis, or a curve, a lateral curve of the spine. Sorry. So we can either have a C-shaped curve, which is obviously in the shape of a C, or an S-shape, which would be a secondary curve that the spine is trying to correct itself. So a few things just to point out in terms of scoliosis. Again, we need to figure out whether it's a flexible scoliosis, or whether it's a fixed scoliosis. If it is flexible, then we need to look to correct it, obviously. And the first point of support we need to offer would be a support on the apex of the actual curve. So that means that the most pointiest bit of the curve. And then we need to put one support above and one support below that, and they're acting as counter forces in order to straighten the spine. Obviously, if it is a fixed scoliosis and you don't have any degree of correction, then we're looking to manage that so that it doesn't get worse. So what we're looking to achieve there is different to actually correcting something. So again, that's quite important when we choose what kind of accessories or supports we put onto the chair, because what we're looking to achieve might be very different. The next slide, we've got, again, I've spoke about kyphosis quite a lot. You can see that it's a curve of the top spine there and can force the neck to go down. Often people with quite severe kyphosis will also develop a secondary curve from trying to get their head to correct itself and be able to have eye-to-eye contact. And that can create quite a lot of different issues around the esophagus, whether it's breathing issues or swallowing issues. And then the hyperlordosis, which is usually caused by an anterior tilt of the spine, and that can can cause a lot of damage to internal organs and put you into a much more difficult posture to be sat in. So when we look at assessing a child, there are a few things we need to look at holistically. So we need to really understand the child's medical history, if there's any past or future surgeries, that the equipment provision that we're looking to get, we need to take all of that into consideration. Will it be the appropriate piece of kit for that child, depending on their needs? Also, if there's any fixations or limitations of their range of motion. I mentioned earlier about becoming chair-shaped and whether or not a child's able to reach that 90-90 that we look for, because if they can't, then it's really going to determine what kind of seating system that child needs as well. They might need something a little bit more supportive. We might need to bring, for example, the foot plates a little bit back because they're not able to reach a full 90 degrees at the knees. We also need to ask a lot of questions. We need to understand the child's needs, obviously, but we also need to understand the needs of the family and the school environment that the piece of equipment might be used in. If it's not practical, if it's not user friendly, it's going to be harder to engage with, and it's going to be harder to engage with the family. So it's also something quite important to think of. So when observing a child for your assessment, it's really important to observe the child both anteriorly and also posteriorly and also laterally whilst they're in their seated position, because that can tell us a lot of what's happening to the pelvis. It can tell us a lot of any kind of curves of the spine. But it's also really, really important, if you want to do a thorough assessment, that the child will be then placed in a supine position. And this is because in a supine position, gravity bears down on us very differently, and we're in a longer position, and we can adopt a much more obviously flat position. So we're able to kind of see what might be flexible and what might be fixed in terms of any asymmetries of the skeleton. We should also look at box or plinth sitting just to see what the child is capable of themselves, so that we're not over prescribing any accessories or any supports that the child doesn't need, and we're taking away their independence by putting them in place. So it's quite a balancing act to be able to reduce that energy expenditure, but also allow a developing child to develop the muscles that are required. So if we move on now to the final section of the presentation, the seating assessment tool. Just a bit of a disclaimer, this was actually derived from the full assessment that is taught at the Oxford Centre of Enablement. And by no means do I mean this to be a full assessment tool. This is simply just a tool that you guys can use within your assessments, just to give you a fuller picture and to give you an idea of what might be going on, and might be red flags for further assessments. So just to be clear, it's just an assessment tool. It is not a full assessment. So as you can see on the left hand side of the screen there, we have got a couple of different sections: creating a stable base, and then below, creating alignment and function. So in terms of creating the stable base there, we've got a lot to look at in regards to the pelvic position and the lower limbs and the feet. So if we take the first one, for example, pelvic rotation. So we're looking at how that presents in sitting. So as I mentioned before, we have a feel of the pelvis and find the ASIS. Now if you can't find the ASIS, and you're not too sure where that is, the advice that was given to me is basically to find a bony part of the pelvis and find the adjacent bony part. So whether you're feeling the pelvic crest or the ASIS is completely irrelevant. The idea is that you're feeling the same bony prominence and you're feeling if there's any difference in between. So if there's any rotation, you might be able to see whether one thumb is in front or behind. So perhaps on the left hand side, you might have the pelvis coming forward, kind of 3 or 4 centimetres. So in that box, you would simply put forward on the left by 4 centimetres. You would go through the whole assessment, doing each one of each one of the points that's made on the left hand side. You do that all in sitting, and then you would come onto a plinth or a bed, for example, if you're in the home environment, and you'd repeat it again in lying. So what that means is if you then did the pelvic rotation again, and you have this, once you've got into a nice supine position, kind of straightened your patient or your client up, you can then feel for that rotation again, and if it's present, if it's still kind of 4 centimetres rotated on the left, then it's likely that might be a fixed rotation. If you get onto the plinth or the bed and it's actually rotated maybe the other way, on the right hand now forward, or you're completely neutral, it indicates that is a flexible asymmetry, and we're looking to correct it. So by working through that form and that assessment tool, you're going to have more of an idea of what's going on. You're going to be able to have a look at the shoulders to see if anything's protracted or rotated, and you're going to have a look at the spine to see whether or not you feel that there is any lateral curves, and if that can be corrected in lying, if it's present in seating. So by no means does this mean that if it's the same in seating and in lying that it is 100% fixed, but it just indicates that you need to go into a bit more detail and you need to go into further assessment of that to find out whether that's a fixed problem. So that brings us to the end of the presentation. I hope this has been useful. If you would like a copy of your seating assessment tool, if you think that would be useful, if you'd like to go into a little bit more detail, please let me know. You can contact us. I can do a further session on the seating tool itself as well, if that would be more beneficial. That's not a problem. And also, if you'd like any references around the information that's been provided, please get in contact and we can provide that. So I look forward to doing the next one, and I hope you find this useful, and let us know if there's anything else in particular that you'd like to know. Thank you.